in regards to independent living assessment, ILA, and activities of daily living, ADLs, presented to you by Sarah Sargent, RN, LTCCC, and Amber Bouvier, RN, LTCCC. This education was developed in an effort to provide a quick overview of ILA questions related to ADLs and IADLs. We will review what the ILA questions are asking and what the different level of care ratings mean and how to complete each question in the ILA. Please note that there may be references in the presentation to things that may not pertain directly to your agency. For example, when we reference requesting minutes for a task, this is specific to the traditional home-based and flexible choice service plans and does not apply to adult family care services, as these service plans are generated differently. However, all information regarding how to interpret ILA questions and answers and what the expectation is for the content of notes applies to all providers completing an ILA. Next. Your note content is valuable. You are already observing when you meet your client at the door, or if you knock and you hear a, "Hey, come in," and you find them sitting in the recliner in a room or laying in a bed in the back bedroom. You are already observing. So observe, observe, observe. What is the individual able to do for themselves? Describe, describe, describe. Document using detailed description of how the individual is able to participate in each ADL. Describe what the caregiver must do to help ensure a task is completed safely. Paint the picture. Describe in detail what assistance is required for the individual to complete the task safely, and include what the individual can do for themselves. Please be sure to include frequency assistance is needed. The ADL self-performance and support provided by paid or unpaid caregiver should reflect what has occurred during the 7 days prior to the assessment. Please note that at times the LTCCC has never met or seen the client you are doing an ILA for. We rely on your observation, skills, and ability to provide descriptive notes to help us paint a visual picture, the individual's environment, their needs, and abilities. Next. Here you will see listed is each of the ILA, ADL category and what should be considered for each task. So describing each ADL, we will start with dressing. How the individual puts on, fastens, and takes off all items of clothing, including donning and removing a prosthesis. Personal hygiene. How the individual maintains personal hygiene, including combing hair, brushing teeth, shaving, washing and drying of the face, hands, and perineum. This does not include personal hygiene in the bath and showers, which is covered under bathing. Bed mobility. How the individual moves to and from a lying position, turns side to side, in positions while in bed, in a recliner, or other type of furniture that the individual sleeps in, rather than a bed. Please note that bed mobility does include from sitting on the side of the bed and lifting the lower extremities into the bed. We will cover more of this later on in the slides. We want to ensure that bed mobility does include the lowering of the lower extremities or putting the lower extremities into the bed in the bed mobility section. Toilet use. How the individual uses the bathroom, commode, bedpan, or urinal, includes transfers on and off the toilet, cleansing of the buttocks and peri area, changing pads depends, managing ostomy or catheter, adjusting clothes. Do not limit the assessment to the bathroom use only. Next. Activities of daily living continued, and please note that these descriptions were pulled directly from the ILA manual. Adaptive devices, putting on or off and removing braces, splint, compression stockings, and other adaptive devices. Transferring, how the individual moves between surfaces, for example, to and from the edge of the bed, the chair, wheelchair, standing position. Exclude from this definition movement to and from the bath or toilet, which is covered under toilet use and bathing. Mobility, how the individual moves between location in his or her home. If in a wheelchair, mobility is defined as self-sufficiency once in a chair. Eating, how the individual eats and drinks regardless of skill, includes intake of nourishment by other means, such as tube feeding, total parental nutrition. Even if an individual who receives tube feedings and no food or fluids by mouth is engaged in the eating, shall be coded. The individual shall be evaluated for his or her level of assistance in the process. Bathing, how the individual takes a full body bath, shower, or sponge bath, excluding washing back or hair, includes washing and drying body. Please note that bathing will be discussed separately as its level of care rating is different than all other ADL categories. Next. Please note that slides 5 through 7, these are level of care ratings that generate the amount of time for each task. Again, these definitions were pulled directly from the ILA manual. So functional assessment and self-performance of all activities of daily living, descriptions, which does not include bathing. Independent is defined as no help or oversight, or help oversight provided only 1 or 2 times during the last 7 days. Supervision, oversight cueing, encouragement and direction, eyes only, no touching provided. And this needs to occur, this level of care provided 3 or more times during the last 7 days, or supervision plus caregiver, non-weight bearing assistance provided only 1 or 2 times during the last 7 days. Limited assistance. Individual is highly involved in activity, receiving physical help, assistance in guided maneuvering of the limbs, touch or guide, or help with maneuvering of limbs but not supporting weight of limbs on 3 or more occasions during the last 7 days, or providing weight-bearing support only 1 or 2 times during the last 7 days. Next. Here we describe extensive assistance. So while individual performed part of the activity over the last 7-day period, help of the following types was provided 3 or more times in the last 7 days. Weight-bearing support or full caregiver support. Weight-bearing support is when a caregiver needs to lift or pick up limbs or bear any of the client's weight to assist with the task. So another example of weight-bearing help, extensive assist, due to a stroke, the individual is unable to move the right arm and leg. Staff must pick up and support the total weight of the right arm to put into the sleeve of the shirt and total weight of the right leg to place in pants. This must occur 3 or more days a week. Another example of extensive assist with full caregiver assist. 3+ days a week. However, not every time the activity occurs. The individual with dementia, whose abilities may fluctuate day to day. Another example of extensive assist with full caregiver is an individual requires caregiver to physically feed them at least 3 days a week. However, the other 4 days, the individual can feed self. Please note that there is a difference between extensive assist and full caregiver assist as we have provided here. Full caregiver assist is 3 times a week, that can be used when example of day-to-day abilities fluctuate, but there are 3 or more days a week in which the caregiver must complete the task for the client, but is not every time. Next. Here's an example of total dependence. So full caregiver performance of the activity every time the activity occurs during the last 7-day period. There is complete non-participation by the individual in all aspects of ADL task. If the caregiver performed an activity for the individual during the entire observation period, but the individual performed part of an activity, him or herself, it would not be coded as total dependence. For example, a quadriplegic who is unable to move limbs to participate with bed mobility tasks, such as grabbing the bed rail, or an individual requires a Hoyer lift for all transfers. Another example, an individual with dementia unable to follow verbal cues or unable to participate physically related to cognitive impairment may be resisting throughout the task and undressing themselves while the caregiver is trying to help them get dressed. And or the client cannot participate in any meaningful way. Activity did not occur in the last 7 days or is unknown. If the activity did not occur at all in the last 7 days or self-performance of the individual is unknown, is when you would select this category. Next slide. ADL and IADL support provided key coding. So here, all activities of ADL and IADL. So no setup or physical help. The individual was totally independent, had no need for support in the last 7 days. Setup help only. The type of help characterized by providing the individual with articles, devices, or preparation necessary for greater individual self-performance in an activity. This can include giving or holding out an item that the individual takes from the caregiver. For example, of setup help only, personal hygiene, providing grooming articles, wash basin, washcloth, and towel, mobility, handing the individual a walker or locking the wheels on the wheelchair, eating, opening up containers at meals, setting up their meal in front of them, making sure that their, drinks are accessible and open as far as how their meal tray is set up. Dressing, retrieving clothes from the closet and laying out the individual's bed. Bathing, placing bathing articles at tubside within the individual's reach. Example of one-person physical assist is hands-on help from one person to complete an activity. Two-person physical assist, hands-on physical help from 2 or more people at the same time to complete an activity. Or ADL did not occur in the last 7 days or unknown. If the activity did not occur or support provided is unknown, you would select this category. Next slide. Here is a snapshot from SAMS regarding ADL. So in section 1A, this is the level of care being provided to the client, independent versus supervision versus limited versus total dependence. This is also the section where you will enter your note. We do ask that the date goes first, and then your note content, and then your initials. The latest note in section 1A will always go on top in ascending order. Section 1B, this is the level of support being provided to the client, whether it's 1 person, 2 person. And the next section is where the time generated based on the level of care versus 10 minutes versus 15 minutes, which is based on the level of care. Next slide. So here we will start with examples of each ADL category. The following slides are the ADL task definition, and a client example for each, and a sample note to support the level of care rating. So here we will start with dressing. Dressing self-performance coding key, and again taken from the ILA manual. How the individual puts on, fastens, and takes off all items of clothing, including donning, doffing, applying, and removing a prosthesis. Example, an individual with severe arthritis affecting upper and lower extremities, poor range of motion, and decreased hand dexterity related to pain. Sample note of extensive level of care for dressing. Individual is able to lift arms into sleeves of shirt, however, requires physical assist to pull shirt overhead and down back. Conveys inability to lift legs independently, requires weight-bearing physical assist to lift legs to thread through pants, and applying socks and shoes at least 3+ days a week. Next. Here is personal hygiene example and sample note. Personal hygiene self-performance coding key definition: combing hair, brushing teeth, shaving, washing and drying of face, hands, and perineum. Example, an individual with severe arthritis affecting upper and lower extremities, poor range of motion, and decreased hand dexterity related to pain. A sample note of limited level of care for personal hygiene. The individual is able to brush teeth, wash face with setup help provided. Individual conveys inability to raise arms high enough to brush hair and requires caregiver to complete. Individual requires non-weight bearing assist to wash perineum while they hold on to walker 3+ days a week. Please note that care for dentures and hearing aids should be captured under personal hygiene section. Next. Mobility in bed example and sample note. Mobility self-performance coding key definition: moving from sitting to lying position, which includes lifting feet into bed. We want to note that this is a new part of the definition to match the MDS. So feet into bed and any assistance provided with that should be documented and including in the bed mobility section. Turning side to side and positioning while in bed, and moving from lying position to sitting on the side of the bed. Example, an individual with severe arthritis affecting upper and lower extremity, poor range of motion, and decreased hand dexterity related to pain. A sample note of extensive level of care. An individual unable to grasp the side rails to physically assist with repositioning, requires weight-bearing assistance to lift feet into bed and turn side to side, related to limited range of motion and pain 3+ times per week. Next. Toileting. Example and sample note and coding key definition. Using the toilet, getting on and off the toilet, cleansing self, and managing incontinence. Example, an individual with severe arthritis affecting upper and lower extremity has poor balance, poor range of motion, and decreased hand dexterity related to pain. A sample note of extensive level of care for toileting. Individual requires weight-bearing assistance to get on and off toilet related to poor balance 3+ days a week. Individual conveys caregiver must assist with cleansing skin after toilet use related to poor dexterity of hands and decreased range of motion. Please note that extra time is granted if assistance with toiling is provided 6+ per day. Next. Adaptive device example and sample note, and coding key definition. Individual's ability to manage putting on or off removing braces, splints, and other adaptive devices. This includes compression socks or compression wraps. Example of an individual with severe arthritis affecting upper and lower extremities, poor range of motion, and decreased hand dexterity related to pain. A sample note of extensive level of care for adaptive device. Individual requires weight-bearing assistance to get compression socks on or off related to decreased hand dexterity and pain. Caregiver must hold up lower extremity, apply and remove compression socks as individual is unable to graft socks to assist 3+ days a week. Please note that other qualified adaptive devices, splints, slings, braces, TED stockings, compression wraps. Next slide, please.
Just to note also, just as a reminder to the previous slide, dentures and hearing aids are not considered adaptive devices. They do fall under the personal hygiene category.
Transferring example in sample note encoding key definition. Moving to and from bed, chair, wheelchair, standing position, excludes to and from the bath or toilet. Again, same example of an individual with severe arthritis affecting upper and lower extremities with poor balance, has poor range of motion, decreased hand dexterity related to pain. A sample note of extensive level of care for transfer. An individual requires weight-bearing assistance to get to standing or sitting position from chair related to poor balance and pain at least 3+ days a week. Caregiver demonstrated how they pull up under the arm to physically assist with sit to stand. Please note that extra time can be granted if assistance with transfers is provided 6+ times per day. It will be up to the case manager to include that in the note. Next slide, please. Mobility example and sample note and coding key definition. Moving between locations inside a home if in a wheelchair, self-sufficiency once in wheelchair. Example, an individual with severe arthritis affecting upper and lower extremities with poor balance, has poor range of motion and decreased hand dexterity related to pain. A sample note of mobility at extensive level of care. An individual conveys they require caregiver to provide weight-bearing assistance by lifting under their arm to support them while they ambulate to the bathroom. Individual ambulates with a four-wheeler and caregiver assist related to poor balance 3+ days a week is required. This is where you would chart time for active and passive range of motion. Active range of motion can be defined as the individual is able to participate and lift their own limbs. Passive range of motion can be described as a caregiver is physically lifting and moving the limbs as the individual is not able to participate. Please note that time only will be approved if physical and/or verbal assistance is needed with exercise. And also note that home exercise programs must be ordered by a skilled professional. A written order must be provided and uploaded into SAMS. If a client has been granted time for range of motion for a long time, despite no order uploaded, the LTCCC will continue to grant with proper notes and justification of support of ongoing need. Next slide, please. Here is eating example and sample note in the coding key definition. Ability to eat and drink, regardless of skill, includes intake of nourishment by other means, such as tube feed or total parental nutrition. Client example. An individual with severe arthritis affecting upper and lower extremity and hand dexterity. A sample note of extensive level of care. An individual conveys they require the use of adaptive utensils related to poor dexterity and pain. 3+ days a week, a caregiver must physically provide weight-bearing support by placing hand over hand for guidance of utensil to mouth. If only receiving nutrition through tube feed, IV route, and not taking anything orally, all time for this will be captured under eating. Meal prep time will need to be removed. Please note that varying abilities day to day and ratings depend on how many days higher level of care is needed. It is up to the case manager to document and note this, as we know that this can change level of care and the level of care being provided. Next slide.
One more thing to take into consideration if an individual is receiving tube feedings or TPN is to note their ability to be engaged with that task. Some individuals may be able to manage their own tube feedings or TPN administration, where others might need caregiver to completely assist. So please make sure you're including those details in your notes for those individuals.
Absolutely. Thank you. Here is the definition of self-performance, all activities of daily living of ADL. And this is bathing only. So we want to be clear that the bathing section is the one ADL that is described and coded differently. So the coding key definition for bathing, which includes shower, full tub, or sponge bath, excluding washing of the back or hair. Independent definition for bathing only is no help at all. Supervision is oversight and encouragement of verbal cueing only. Limited assist is help transferring in and out of the shower only. Extensive assistance is described as while the individual performed part of the activity, physical help in part of bathing was included and provided. Total dependence, described as full caregiver performance of the activity every time the activity occurs during this last 7 days. There is complete non-participation by the individual in all aspects of bathing. Or activity did not occur in the last 7 days or is unknown. If the activity did not occur at all in the last 7 days or self-performance of the individual is unknown, you would select this category. Next slide.
One thing I want to point out with bathing, while the definition says to exclude washing back or hair, that is the case in terms of choosing your level of care rating. So you need to base your level of care rating on the individual's ability to wash and dry their chest, legs, arms, rest of their body. The help that they need for washing their back or hair cannot count towards your level of care rating. However, in the time that's granted for bathing, the task of washing their back or hair is included in the task itself. It just can't be counted towards their level of care rating.
Absolutely. So an example of bathing in sample note, encoding key definition, which includes the showering, full tub, or sponge bath. For example, an individual with severe arthritis affecting upper and lower extremity struggles with getting in and out of the tub related to poor balance, needs physical assistance to wash bilateral lower extremities, peri and buttocks area. A sample note of extensive level of care for bathing. An individual conveys they need physical help in and out of tub or shower related to unsteady gait. Observed a shower bench in tub shower combo, noted grab bar on wall to hold on to. Once seated, individual able to wash face and upper body independently, however, requires physical help to wash in lower extremities related to inability to safely reach without significant pain. Next slide.
Okay, we're going to continue on. You may have seen the common theme in many of the prior slides regarding the client example. And we're going to carry on that same theme with the IDL tasks. We're discussing the same individual who has the severe arthritis, upper and lower extremities. They have poor balance, poor range of motion, and decreased hand dexterity related to pain. So we're going to continue to carry through that individual's example. And you'll see the common themes in all of the notes that we covered under each ADL section all kind of had the same basis of information. And we're going to continue that with the IADL tasks. So it's important in your notes to include what the patient can do for themselves, what their caregivers must do to help them, what's being reported, what's being demonstrated, an explanation of exactly what kind of help is needed and how often on a weekly basis. Those are the main parts of your note, and we're going to continue to carry that through in the IADLs. So we're going to talk about meal prep, the coding key example, and sample note. So meal prep is defined as planning and preparing light meals or reheating delivered meals. Same client example as we've had all along. So with IEDLs, our level of care rating, we look at if an individual is independent, if it's done with help, or if it's done by others. So for this particular example, we're going to look at a note supporting done by others level of care. So the individual conveys that they require use of adaptive kitchen utensils related to poor dexterity and pain. The caregiver must cut up meats and vegetables, open canned foods or food packages. An individual cannot safely stand long enough to cook at the stove due to poor balance. In your notes section for meal prep, please indicate if the individual receives home delivered meals, such as Meals on Wheels, and how often. Is it just Monday through Friday, or are they getting the frozen meals for over the weekends? Just another note in regards to meal prep. Just a reminder that spouses cannot be paid for meal prep or medication management, in addition to the standard amount of IEDL time or respite and comp time. And that's something we can cover more later. So if the spouse is the sole paid caregiver, we need to remove time from these categories. So let's talk a little bit more about IEDL and meal prep reduction of time, because there are times where an individual should not receive the full allotted amount of time. So if an individual receives Meals on Wheels or home delivered meals, we are not going to reduce or adjust the meal prep time. And there is a memo linked to this presentation, so you can read, I think it was dated back to 2018, specifying that. So you're going to keep the time as requested and can be up to the max amount of time or less, depending on what the case manager documents for the need. If an individual attends adult day, then generally speaking, we would be reducing the amount of meal prep time based on the number of days that the individual is going to adult day because they provide meals there. So again, the case manager needs to document the need. If the client's receiving meals at adult day, breakfast, lunch, etc., it needs to be documented in the note along with the number of days per week. Time should be reduced unless there is a good reason based on the case manager's documentation. The LTCCC will use their best judgment and critical thinking skills to determine, based on the documentation, to support the requested time not being adjusted. For example, if an individual has very specific dietary needs and must bring their own lunch to adult day, that would be a good reason why we would allocate the full amount of time for them, because their meals still need prepared in the home. In terms of shared households, if an individual does not live alone and shares a household with others, IEDL time and meal prep time should be reduced by half, generally speaking. Again, unless there is a good reason based on documentation not to do so. The LTCCC will use their best judgment and critical thinking skills to determine based on the documentation to support the requested time not being adjusted. For example, if an individual has specific dietary needs and their meal needs to be prepared separately from the rest of the household, or if an individual lives in the same home as others, but their living spaces are not shared with the rest of the household. Maybe they have an in-law suite, and so they have their own bedroom, bathroom, kitchen area, all of that, and their living space truly is separate than the rest of the house. Because the full amount of time given for meal prep and IEDL time is based on a whole household's worth of time. Many of our clients, their caregivers, their paid caregivers, live in the same home as them. So in some instances, we may be having paid that caregiver to be cooking their own meals, cleaning their own environment. And that's not really ethical use of Medicaid funds. So we need to make sure that we're justifying the amount of time that's given for those categories. Another example where it would be appropriate to grant the full amount of time for IEDL time for an individual. Maybe the home is in severe disrepair. It's a hoarding situation, and there's just significant environmental needs in their home. That would be another appropriate reason to request the full amount of time. Now, please note that this will be standard going forward for all new applicants, as well as existing applicants upon reassessment. So as you're doing reassessments or changes, please make the time adjustments and document your notes accordingly to support the amount of time that you are requesting. Okay, let's talk about medication management. So this is defined as taking all prescribed and over-the-counter medications reliably and safely. We're using the same client example, the severe arthritis affecting upper and lower extremities with poor balance, poor range of motion, and decreased hand dexterity related to pain. So we provided two different level of care sample notes. First one is done by others. Individual conveys they require caregiver to call in refills, pre-fill the weekly pill organizer, and remind them to take the medications when due and administer the medication to the individual. A sample note for done with help level of care. Individual conveys they are unable to open pill bottles and occasionally forgets to take meds as scheduled. Requires caregiver to pre-pour into a pill planner and provide reminders daily. Now, please note that wound care needs should be reflected in the medication management section. For any wound care needs that we are requesting time for, there needs to be an order for that wound care as prescribed by a skilled professional. The order should specify the frequency of wound care, and the case manager's note should include the individual's ability to participate in the task. For example, if it's a simple wound where all it needs to be is cleaned with soap and water and a new Band-Aid put on, and it's in an area that's easy for the client to reach, they may be able to do that themselves, in which case we wouldn't be requesting time for that. However, if it's a more complex wound, maybe in an area where the individual can't reach, can't see, then it would be appropriate to request case manager to ask for time for the caregiver to be paid for that task. But again, we have to have that order specifying how frequently that wound care needs to be completed. Okay, let's talk about incontinence time and where to account for it, because this is a question that we get all the time. So let's try to help differentiate between each category. So we have toileting time, incontinence time, and personal hygiene. So toileting is the act of getting on and off the toilet, commode, bedpan, what have you, cleansing the skin, pulling clothing up and down, and changing the depends. Incontinence time is the extra time that's needed to change clothing or linens when the incontinence goes beyond the brief or pad. This is extra time in addition to the regular toileting time. So again, toileting time is the act of using the toilet, commode, bedpan, cleansing the skin, and managing the clothing. Incontinence time is the extra time needed to manage soiled clothing or linens due to incontinence. Now, personal hygiene in that category, it does specifically talk about pericare. The only time that you would be coding for pericare under personal hygiene is when assistance is needed with cleansing the peri area when an individual is not incontinent and it's not related to toileting. So it would just be their daily hygiene. It would also apply to if an individual needs creams or powders, such as barrier cream, antifungal powders, what have you, applied to those areas. Okay, variance requests. There are times where the generated amount of time that is just standard based on your level of care rating is not the appropriate amount of time for an individual to receive their care. So if you are asking for extra time for a task, you would be putting in a variance request. Now, again, this is specific to home-based and flex choice individuals. This is not applicable to the adult family care home service plans. So a variance request is additional time needed because an individual's needs cannot be met within the allocated time that is standard based on the level of assist for a given task. Some common reasons why a variance may be requested. Maybe your individual has dementia and they're extremely resistive to care. So the length of time to complete a task is going to be significantly more than a standard amount of time. An individual with COPD that has severe shortness of breath that needs frequent breaks throughout the duration of ADL tasks. Some individuals with end-stage COPD truly can't do more than 30 seconds work before they need to sit and take a break. They can put their pants on, but then have to stop and breathe for a few minutes. They can brush their teeth, but then they have to stop and catch their breath. So in the long run, those tasks are taking a lot longer. Maybe it's an individual with multiple sclerosis. They have muscle spasms, and the caregiver needs to give time to allow for the spasms to subside. When they're moving their limbs, their muscles can become rigid and spasm. And if they keep moving them, they can cause pain or even injury to the individual. Or maybe it's an individual who's a quadriplegic and needs two caregivers to assist with reposition and bathing. Keep in mind that variances are not limited to these examples, and understanding that variances are a case-by-case basis and require supportive notes by the case manager to be considered for approval. Time requests should reflect individuals' specific needs and may not always require the full allotted time. So while we're here talking about variance requests, so requesting extra time to complete a task, there may be times where the standard amount of time that's generated not necessarily needed. Maybe, for example, an individual requires non-weight bearing assistance with dressing, and really the only help that they need is with buttons or zippers. So it's not going to take caregiver 10 minutes, for example, to zip a zipper or button a couple buttons. So just in the same respect as requesting extra time to meet a client's needs, it's just as appropriate to reduce the amount of time to only what is actually needed. And again, keep those information pieces in your notes. Justify why you're adjusting time, whether you're adjusting it up or adjusting it down. Okay, so here is another snapshot back to the same screen in SAMS. And we'll talk through where you're going to put your variance time requests. So again, we have 1A, which is the category where you're choosing your level of care rating, supervision, independence, limited assist, extensive assist. That generates a certain amount of time. This is also where you're going to put all of your notes, is in the 1A over to the right in the notes column. Again, line B, is the support provided, whether it's setup help only, one person assist, or two person assist. That third box down where it says dressing estimated minutes per day, that box that has the 10 in it, the first box, that is the computer generated amount of time based on your level of care rating. The next line down, 1C1, that box that has the second 10 in there, that's where you're requesting the specific number of minutes per day that you're requesting for that individual. So if you're requesting variance time, that is where you're going to increase the amount of time. So say you were applying for a variance for this individual saying that they needed 20 minutes to dress. You would change that second box that has a 10 to 20. Or as we discussed a few minutes ago, if an individual maybe only needs help zipping a zipper, you're going to reduce that second box of 10 to the number of minutes that it would actually take. Maybe 3 minutes, something reasonable. The next line down, 1C2, these are the number of days per week that you're going to be requesting those minutes. So for example, maybe an individual only wants to change their clothes every other day, or maybe shower 3 times a week. So that box where the 7 is, that's exactly where you would change that to the number of days per week that the task is going to be completed. So if we're reducing it to every other day, it would be 4 days per week. If an individual only wanted to shower 3 days per week, you change that 7 to a 3. And again, your variance request should be contained in your note in 1A. So in that note, you want to really clearly justify why that need is for extra time. What's the unmet need that is requiring more time? Why is it requiring more time? What is the risk to the individual if that extra time is not granted? Are they at risk for falls? Are they at risk for skin breakdown? Those kinds of things are very important to put in your note to justify that variance request. At one time, it does not automatically mean that it's going to be approved going forward. So each time you do a reassessment, you should be providing new notes justifying the ongoing need for that variance time. Okay, let's talk about duplication of services. Case managers must be sure there are no duplication of services, as Medicaid should be the last payer source to be utilized. There's a couple different ways that duplication of services could potentially happen. One example is ADL time being captured in multiple categories for the same task. So going back to that slide where we differentiated between toileting, incontinence time, and personal hygiene time, if you're not documenting and capturing the time in the right categories, it could be considered duplication of services. Another example is if an individual is receiving other supports from paid sources like VA or hospice or skilled nursing services, physical therapy, occupational therapy, those kinds of things. So it's important for the case managers to capture all of that information in their notes in the act that would be duplicated. So sometimes with VA services, they're sending in a homemaker to do household IEDL tasks. So we would want to reduce the IEDL time accordingly based on how often those provided. Maybe the individual is on hospice, and most people who are on hospice services receive a home health aide from hospice, usually at least once a week, sometimes more often. And when that hospice aide is there, they are taking care of bathing, dressing, and personal hygiene tasks. So the case manager would want to reflect these services through hospice in those categories that are being provided by hospice. So in the notes for dressing, personal hygiene, and bathing, you should include the hospice support and how often that's happening. And then reduce the number of days per week that you're requesting that time for. So if a hospice aide is going in and giving the individual a bath 2 days a week, in the bathing category, you're going to reduce the time by 2 days a week. Same thing with dressing. and personal hygiene. Some just little tidbits of information that are helpful and we wanted to just make reminders of. And some of these we've already covered, but we're just going to go over it anyway. So again, a reminder that all details or notes should go in the A section for all ADLs and IADLs. I know in years past, they used to go in the D section, but that is no longer the case. All notes should go in the A section. They should be in the format of the date, your note, and then your initials with the newest note on the top. Do not use the comment box for details. Anything that you put in that comment box cannot carry over year to year. So, you put it in there, the next year you copy the last UR, it shows up in that box, but in order to put something new, you have to delete the text that's in there. So last year's text is now going to be gone. So instead of putting any text in the comment boxes, click on the notes in the top right corner and then enter a full note with details on the right side column in the text box. Notes need to be applicable to the specific category that it's being noted in. So for example, please don't talk about transfers when you're discussing toileting, because toileting transfers are different than regular transfers. Just making sure that the notes are specific to each category that they're aligned with. You can use the term no change in your notes only if there is actually no change at all to the answers or details to that question since the last assessment that was done. If there's any change in the information since the last assessment, you need a full note explaining those changes and giving the current status. Using no change also cannot be used more than 2 times in a row. So generally speaking, we keep 3 years worth of notes in the ILAs to reference back. So if you use the first note as a robust, good note with lots of details that is still applicable to today, you can use no change the following year and the year after, as long as it's still correct. In those last 3 years, there has to be at least one well-rounded, supportive, robust note with lots of details to help justify that category's level of care rating. Another reminder, all ILAs must be done by copying the last utilization review. Please do not copy the last ILA. It's very, very important to copy the last UR because when us LTCCCs do a UR, we might be making changes to things and corrections to certain categories, or maybe we're approving a variance request. All of that stuff is very important that it gets carried over assessment to assessment. So again, do not copy the last ILA, copy the last utilization review done by an LTCCC. Now, if the observations that you make do not match what is being reported by the individual, put both sets of information in your note. And ultimately, you're going to choose the level of care rating based on your observations. The health review section. Please make sure that you are updating all area notes with each reassessment. Do not leave them blank. I know this last year was the first year adjusting to the new health review section. So there were definitely some growing pains with that. But again, please make sure that you're updating all areas with pertinent updated information. Do not leave them blank. And also note that when us LTCCCs do an initial assessment, a clinical assessment, you copy that into your initial ILA. We don't have all of those questions in the health review section for us to fill out. So many of them will be blank with your first assessment and will be up to you to complete that information. And just a reminder that IADL time does not auto-populate like the ADL time does. In ADL categories, you choose your level of care rating, the amount of time generates, and at the end of the ILA, it adds it all up. That is not the case with IEDL time. You must enter the 270 minutes, which is the standard amount per 2 weeks, in 2.c LTC waiver calculated needs. That's the title of that section, and it's the section just before the beginning of the service plan. Now, again, going back to a few slides back when we talked about shared households and reducing the IADL time. So that 270 is where you would be reducing that time accordingly. If it's a shared household, generally speaking, you're going to reduce it down to 135. Also using the narrative tab to give a brief summary of the individual's condition and any significant changes. It's wonderful for us to see summaries in that narrative tab. When you're doing a reassessment, give us a little synopsis of what's happened over the last year, any significant changes or new medical issues. It doesn't have to be a long, intensive note, but it should contain any pertinent information that we should be aware of. Let's talk about start dates. So there are 3 different kinds of start dates and different rules for each one. For an initial ILA, so somebody who's just coming on the program, your start date is going to be the date of the application. However, that's only if the initial ILA is completed within 14 days of the alert from the LTCCC or within the time frame of an approved extension from the LTCCC. So when we do our clinical assessment, we formalize it into the system and we send an alert to your agency letting you know that there is a new client that needs to be assigned. You have 14 days from the date of that alert to complete your initial ILA. However, if you're unable to get that completed in 14 days, have a communication with your LTCCC via an alert in SAMS requesting an extension and what date you're requesting that extension be to. So if we approve an extension for another 2 weeks, as long as that initial ILA is completed within the time frame of that approved extension, you can go back to the date of application for your start date. However, if you do not make that 14-day deadline and you don't have an approved extension, then the start date is going to be the date that the ILA is submitted back to Dale. So the date that there is an alert sent in SAMS back to us that the ILA is ready to be reviewed. If it's a reassessment, it really determines whether ARIS is in the service plan or not. So if on reassessment, if the service plan contains ARIS, then the start date should be the closest ARIS payroll start date prior to the end of the current service plan. If ARIS is not in the service plan, then the start date will be the day following the end date of the current service plan. So if the service plan ends February 1st, the start date for the next one will be February 2nd. If it's a change assessment, again, it comes down to whether it's an ARIS service plan or not. If ARIS is in the service plan for a change assessment, then the start date should be the next upcoming start of the ARIS pay period after the date of submission to Dale. If ARIS is not in the service plan, then the start date will be no earlier than the date the service plan is submitted to Dale, which is the date that the alert is sent in SAMS. So it doesn't have to be that day, but that's the earliest that it could be. There may be times where it's appropriate to request a retroactive change request. So retroactive requests for an increase in home-based services will be considered for approval only under certain circumstances. When a precipitating event necessitates an immediate increase of services exceeding the currently approved volume of services. The immediate increase must be necessary to prevent harm to the individual, a hospitalization, or nursing facility placement. For example, the home-based primary caregiver is hospitalized, or the individual has a medical event that requires immediate increase in services. Retroactive service plan changes will not be approved to cover administrative errors or non-emergent requests for increases. All requests for retroactive coverage must accompany a service plan with change ILA and a written request for a specific start date and a description of the precipitating event. Okay, that is the end of our formal presentation. We have put together a list of frequently asked questions and their answers. So hopefully that between the presentation and the FAQ page, your answers can be, your questions can be answered. However, if you still have outstanding questions that are not answered within the presentation or the FAQ page, please reach out to your local LTCCC and ask them for information. We can't encourage enough for everybody to have conversations with your LTCCCs. We are here to support you and work together for the better of the clients that we serve. So coming to us for more information or guidance regarding specific situations or questions in the ILA, it's always great to have that dialogue and be able to help figure things out together. So don't hesitate to reach out to any of your L2CCCs at any point in time. And we look forward to continue working with all of you. Thank you so much. Have a great day.